Good. Glad to hear it. Well, thank you for agreeing to spend part of your evening with me. I need to run through some quick disclosures, and then we'll talk about more interesting matters. So you already know I'm Stephanie, and I work for an independent market research agency called Ipsos Healthcare. We've been retained by a pharmaceutical company to speak with a variety of clinicians to gain an understanding of how patients who experience constipation as a complication of neuropathic disease present and are treated. This is not a promotional discussion. It is strictly for market research purposes, and everything you share with me is kept in confidence. I follow some important market research codes of conduct, and one of those is that we don't reveal your identity to the client. So we're on a first-name basis today. I'll just call you Dr. R if you don't mind. And you do have the right to refuse to answer questions, or you can withdraw from this process entirely at any point in time. You do need to be aware that we're recording, and that's so I have a record to refer back to for analytical purposes. The recording may be heard by representatives of my organization or the client organization because they all like to hear things firsthand. And lastly, you're probably aware that in the event you mention an adverse event or a product complaint that you have observed in a specific patient or a specific group of patients with one of my client's products, I am obligated to report that even if you've already done so. If that happens, we'll talk about the process for reporting and confidentiality and all of that good stuff, but we'll cross that bridge when we come to it. So let me just see whether you have any questions for me and confirm that you're still willing to go ahead with our discussion.
Yeah, okay to go ahead with the discussion, no problem.
Okay, wonderful, thank you. So let me ask you to begin with an overview of your practice, without naming it, of course, but I'm interested in the other providers, how many other providers work there with you, and the kinds of things you focus on, and the type of community that you serve.
We have the total 4 physicians between the 2 offices. We are the internal medicine primary care practice. We are in the suburban area. With the 1 office is in the little bit kind of the lower socioeconomic status area, kind of the rural area kind of the thing. And we see all varieties of the patients, yeah.
Okay, all right, and all age ranges as well?
No, we usually see the adult from 18 and above.
Okay, all right. Very good. Well, that's helpful. Thank you as a starting point. So I'd like you to think about the patients you currently treat who have Parkinson's disease specifically. And I'm curious what percentage of them experience constipation as a complication of their disease.
About 80% of them have the constipations associated.
Okay. All right. Now, do you have the sense that they experienced constipation before they were diagnosed with Parkinson's, or is this something that kind of comes up, you know, once their disease trajectory has begun?
Many times, like during the treatments and on the further questionings, patients come up that they have the additional problem of constipation. Sometimes during the examinations of the patients, like then you discuss more, then we know that the patient also having the constipation. Sometimes patients bring that, I also not moving my bowel the way I used to do before.
Mm-hmm. Okay. All righty. Now, are they prepared that this may be a complication of Parkinson's? I mean, do you draw that relationship for them? Are they aware that there may be a relationship? What do they understand about constipation and Parkinson's?
Most of the patients, they don't aware that the constipation is a part of Parkinson. Many times they think that this is the age-related process, so that's what it is, yeah.
How severe does it seem to be?
It's like some patient it's like the kind of the severe. Some patients like they try to manage by themselves because they don't think that the constipation is like the major issue. They try to manage by the drinking fruits or trying the over-the-counter laxative and try to manage by themselves. Yeah, some patients affect their lifestyle significantly, so they talk to the physician right away, and we interfere with we try to give some medications and adjust the thing.
So what does it look like? What kinds of things do they say that would make you think has a significant lifestyle impact?
Yeah, many times the patients having the abdominal pain, they having the nausea, they have the loss of the appetites and everything. Some patients, because of the constipations, they couldn't able to participate in their day-to-day activities. So that's kind of the things affect the day-to-day lifestyles, and they discuss with us so we can kind of help them.
What did I want to ask you? I completely lost my train of thought. Oh, so where does constipation fit with respect to the other kinds of things they're complaining about or having to cope with their Parkinson's? I mean, how big of a deal is it?
Yeah, that's a good question. Like some of the patients, they think it is a part of and parcel of their process, aging process. Some of the patient, this is a very significant issue, and some of the patient may end up to the emergency room because of the constipation also.
Okay. What percentage would you say seem to experience this sort of severe or significant impact? How predominant is that among your Parkinson's patients?
About, I can say about severe is about 8 to 10%, yeah.
Oh, so not a big number that experience it as a significant thing.
Yeah.
Okay. All right. Now, why do they find themselves going to the emergency room? What is it that takes them there in the middle of the night or whenever?
Yeah, because like many of these Parkinson patients are the older group of the patients, and they having this things like the constipation going on for quite some time, and then the time comes like that constipation lead to the small bowel, like the obstructions, paralytic ileus. They start having abdominal distensions and pain. And then immediately the caretaker or the patient call 911, and many times they end up in the emergency room because of the associated symptoms, which ultimately caused by the underlying constipation.
Is that more common when you say they're older patients? I mean, is that happening more commonly in someone who's, I don't know, 80 plus, or do you find that behavior of going to the ER? Are there any patterns around that?
No, there is not any specific pattern around that. I think it's not one factor related. It's like the multiple factors kind of the affecting things. So like some of the patients who are the multiple medical problems, beside the Parkinson, they are also having other chronic pain issues, who are also additional on the narcotic or opioid for their controlling the pain, which also contribute the more constipation.
What percentage are taking opioids for pain?
About I can say about around 10 to 12% of patients.
Now, is someone else prescribing that opioid, or is that you?
No. Many times, we manage the pain things. Some patients follow the pain management doctor. Sometimes the pain is also managed by the neurologist also. Okay,
but you may be writing it as well. You're not reluctant, or it's not like you never write them?
No. We write the opioids, but we don't write prescribe for the long-term opioid management. We don't know if the patient need the long-term opioid management. Then usually we refer them to the pain management. Yeah.
So you use the phrase pain doctor. Is there a specific specialty that goes along with that description?
Yeah. Usually, like the pain management doctor are usually the anesthesiologist, and they after the finishing the anesthesia, they usually do the fellowship on the pain management because they are the one who they do the spinal and everything, where they do easily do the spinal blocks and all that thing.
Okay. So on an ongoing basis, a Parkinson's patient might go to an anesthesiologist for pain treatment?
Not anesthesiology, pain management.
Oh, I thought I heard you say anesthesia. I'm curious if,
No.
Is there another name for that specialty?
No, the most of the rest is like the who finish the anesthesia, they do the fellowship in the pain, and they are kind of the code call as a pain management. Yeah.
Okay. Okay.
Yeah.
So these patients, again, your Parkinson's patients who have constipation and they're complaining about it, have they often spoken with another physician besides you about this condition, or are you sort of the first line of defense here?
No, usually the primary care is the first line. Yeah.
Mm-hmm. Okay. All right. When you think about this constipation that has what you call a significant lifestyle impact compared to less of a lifestyle impact, I'm curious whether you assign any language or labels to understand that continuum of constipation. I mean, how would you describe it to a colleague if you were talking about someone who had a significant lifestyle impact versus a lesser lifestyle impact?
Usually the patients who has significantly affected, usually they tell us that I didn't have bowel movement for last 4 or 5 days, sometime more than a week, and this is the doc, it's like the kind of the making me discomfort, and you need to take care of this. That's what kind of the many times directly they discuss with us.
But I'm curious, if you were, notating that in the chart, would you refer to that in a certain way, like, severe, neurogenic?
Usually,
I mean, yeah. Well, how would you label it?
Yeah, like as a diagnosis or in the HPI.
Yeah, as a diagnosis and to
diagnosis.
distinguish.
Constipation, secondary constipation, like whether it is from Parkinson or whether it is spinal cord injuries or something like that. Yeah, or the opioid-induced constipation. So there are the different secondary constipations and different etiology.
Okay, and would you add any qualifiers to that to say it's severe secondary constipation, or to make any description of that lifestyle impact?
Usually we don't put like as a mild, moderate, or severe, because usually constipations when we put as a diagnosis, usually most of time we know that it's affecting the patient day-to-day lifestyle. Yeah.
Just by virtue of having the diagnosis
exactly,
of secondary
yeah,
constipation.
Exactly, yeah.
Okay.
Exactly, yeah.
How would you, if on a follow-up visit a patient told you that it had gotten worse, would there be any language to express that? I mean, what would you say?
Yeah, usually we mention that not responding to the current line of the treatment.
Okay, and that's it. Okay.
Yeah.
Mm-hmm. Are some patients, Parkinson's patients, worse than others with their constipation? I mean, is there any characteristic or profile that you could say, yes, those patients tend to experience it more as being a bigger problem than others?
I don't think so. There is nothing like any specific that this kind of the Parkinson are more prone to the severe constipation. No.
Mm-hmm. Mm-hmm. Does their constipation get worse over their lifetime as their Parkinson's progresses?
I don't think so. As the Parkinson get worse, that constipation is not direct. It can get worse, but not only solely related to the worsening of the Parkinson. There may be just some other contributing factor also.
Like what would they be?
Like their age, and also getting more deconditioned maybe developing some other medical problem, limited mobility and all other contributing factors.
Mm-hmm. Are there any comorbidities in particular that seem to contribute to worsening constipation?
Yeah, like the people who have the advanced diabetic, they also more prone to develop diabetes. People who have the, as I mentioned before, the chronic opioid treatment, people who have the advanced osteoarthritis leading to have them poor mobility, so poor access to the fluids and everything, that all contributing factors.
Mm-hmm. Mm-hmm. Okay. So how do you approach the problem for the patients who complain of it?
Yeah, depending upon the overall conditions, we initially start with the lifestyle changes, increase the fluid intake, increase the fiber supplement, and then start laxatives to help them out. Yeah.
And are those sequential? You try one at a time, or do you recommend all of those at once you've heard the complaint?
No. Usually I try, it depend upon what the patient have tried. Sometimes they already try the over-the-counter medication. So in that case, many times if they didn't take the enough dose, then I may advise them to take the enough dose, even though some patient already tried a couple of them. We tried the prescriptions laxative, like the lactulose or the Amitiza, Miralax, Linzess, so many different medication available.
Mm-hmm. How long do you want them to persist with a fiber supplement, maybe an over-the-counter laxative, before you start to entertain the prescription options?
Yeah, usually it's like the individual case scenario. Some patients are who already tried over the counter, which not helping, and then on examinations and from history, I know that they have the kind of the moderate to the significant constipation. Then immediately I go for the prescription medication. Some patients their symptoms are not that significant constipation, they didn't try anything over the counter, then we can try with the Miralax osmotic laxative and see how you do. So each individual patient is different, depending upon how bad is the symptom, depending upon what the medication so far they tried. Then we can decide according to whether we can try with the over the counter, whether try directly go for prescription medications.
Mm-hmm. Yeah, I know. I always frustrate physicians when I try and pin them down on something specific, and I always get that answer, it's highly individual. Every patient is different. So I appreciate that I'm giving you a hard time here. But let me try to pin you down all the same. Generally speaking, if someone hasn't tried an over-the-counter approach on their own, how long would you recommend that trial of the over-the-counter be?
Maybe about a week or 10 days the maximum, yeah.
Oh, okay. Okay, and what percentage would you say have usually tried that over-the-counter approach on their own?
About the 70 to 75% already tried over-the-counter medications, yeah.
Mm-hmm, mm-hmm. Okay. So then you rattled off a bunch of drugs for me. I think I heard you say Amitiza. I heard you say lactulose. Maybe there was another one in there. How do you decide which one to start with?
Yeah, that's also a good question. There is nothing like the specific. Sometimes we try with if patient didn't try anything, then we can, many times I want to try sometimes want to try the best medicines like the Linzess or some other medication, but many times the insurance doesn't approve. Sometimes they want us to try the step therapy, so we have to try with the one which is a generic, like the Miralax or lactulose or the Sena S or Coles, and then if that doesn't work, then we go to the next level of the medications. Yeah. Yeah.
Now, I think I heard you say the best medicine, Linzess. Did I hear you accurately?
It's not like but they are the newer one, which are the local acting, and I have seen they have the very good response, like the Amitiza, Linzess, Trulance, all these medications. Yeah.
So you're calling all of those three, Amitiza, Trulance, and Linzess, those are all sort of the best, quote unquote?
Not like the quote unquote, but they are the newer one with the locally acting, and I have seen the better response. Like the another one is called as a Movantik. They are also the good medications. Yeah, but the problem is that the many times the insurance company don't approve at the first instance. Yeah.
So are you checking the insurance before the patient leaves the office, or you give them a bunch of samples and how does that work then? I'm just curious.
Yeah, so like we give like the patient already tried, and we give them some sample if we have, and then send the prescription to the pharmacy, and if the insurance don't come, and then pharmacy send us the paper back, and then we have to do prior authorization process.
Okay. If insurance were not a feature of this treatment, so let's live in fantasy land for a moment. You know, if you didn't have to contemplate the possibility of a step edit or a prior authorization, or whether you have samples even, which one would you prefer to write first?
Yeah, so in that case of scenario, I will go with the Linzess.
What is it about that appeals to you, or that you think is makes it a good player?
Yeah, it's like the locally acting, not much drug-to-drug interactions, and so far in my clinical practice, I have seen the very good response, particularly the patient who have the kind of the neurogenic constipations, opioid-induced constipations, idiopathic constipation. In that cases, I have seen good response. Yeah.
So the same response whether we're talking neurogenic or idiopathic?
Yeah, I think they work very good for the both kind of the patients. Yeah.
When you say you get a good response, what percentage would you say do not respond adequately, have an incomplete response to Linzess?
Yeah, maybe about like the 25 to 30% may not respond like the way the other 60 or to 70% of the patient response. Yeah. So in that case, we may have to modify the treatment, may have to add something else. Yeah.
Okay. That's what you do next. You'd add something?
Yeah.
What would you add?
Yeah, it's in that case like I go with the Miralax, ask the patient to take instead of once a day, usually, which is the standard dose, but sometimes we end up with asking them to take at least twice a day. Yeah.
And if that doesn't do the trick, Linzess plus Miralax, what might you do in that scenario?
Yeah, then you have to find out you are not dealing anything else, like you thought that maybe the constipation is neurogenic or the other. Then you need to find out is there any other etiology, patient may having any rectal mass, or he's having any strictures or something like that.
And so how do you do that?
Yeah, it's like then you try to do the blood test and to see whether patient is iron deficiency anemia, or whether you do the rectal examination to see whether sometimes the patient has a significant fecal impaction, so which require the manual evacuations, and then the medicine start working, or he may having some mass, or you may have to refer them to the GI to do the colonoscopy, that kind of the next level of the treatment. Yeah.
No, that's kind of where I was headed. I was curious at what point you might consider referring them.
Yeah, that's the case. Like as I told you, even after I know that I tried the significant medications for significant period of time. I know that a patient taking his medications regularly is also changing lifestyle, still is not affecting. Then it's time to rethink and see what are the other etiology, and then we refer him for further workup.
Okay, but here's where I'm getting a little lost. Forgive me. So a rectal exam, feeling around for impaction or strictures and doing some blood work, you would do all that, and then if something was not looking kosher, then you would refer, or the GI doctor would do the evaluation for strictures and masses and whatnot?
No, the GI doctor will do the colonoscopy. If the patient is fragile, then he may do just barium enema.
Got it. Okay. Terrific. Thank you. Now, I'm curious if anything that you've described to me, this sort of over-the-counter regimen, this trial, kind of short-term, then looking to insurance to drive your first-line prescription therapy, Linzess, if you can get it. What's different in that approach if we were talking about chronic idiopathic constipation, if anything?
So if the patient can get whatever he want to get, or what?
Yeah, well, yeah, I mean, you described for me, fiber and laxative, and then if that's not really working, that you would go to a Linzess or whatever they might have access to. I'm wondering if that would be any different if this were not a patient with Parkinson's. It's just a normal patient who's complaining about constipation. Would you still prefer Linzess? Would you still do a 7 to 10-day trial of something over the counter? What might be different if the patient did not have Parkinson's, if anything?
Okay, yeah. Yeah, so in that case, I would definitely, if the patient have no other neurogenic or the Parkinson's or anything, then I would try the over-the-counter medication, because now the prescription, Miralax used to be prescription, now it is available over-the-counter. So I try that, make sure that the patient taking the enough dose, because that's what many times the problem. Patients say that they are taking the medication, but they are not taking the enough dose of the medication. That's why you don't see the good clinical response. But the reason is that they are not taking the way they are supposed to take. Yeah.
Mm-hmm.
Yeah, and
okay.
if that then after that you don't see the good response in spite of taking the medications in correct dose, then you go to the next level of care. Yeah.
Okay. So it sounds like it's pretty much the same. There's nothing.
Yeah, almost. Yeah, more or less. Yeah, more or less same. Yeah.
Okay. Mm-hmm. So when you think about Linzess and Amitiza and Trulance and Movantik, I'm curious, what's still missing? What's still an unmet need in that armamentarium for patients with Parkinson's?
As far as the treatment concerned?
Yeah. Well, I mean, if you could speak to a drug development expert tomorrow, what would you suggest they start evaluating and pursuing?
Yeah, in that case, I probably maybe they can try to develop some kind of the stimulant which increase the peristalsis, and that help the kind of the natural ways to stimulate the natural peristalsis of intestine that help the patient with the constipation.
Okay. What else? What other opportunities to improve on what you already have?
Or maybe they can come up with some medication with the dual mode of the action, because there is not a single medication which has two different mode of the actions. If that's the case, it's good kind of the things to consider about it.
So something that is pro-secretory and pro-kinetic, or some other mechanisms you're thinking about?
Yeah, pro-kinetic, and same time like the bulk forming. Yeah, so that kind of the mechanism.
Okay. Bulk forming plus the peristalsis.
Yeah, like the prokinetic, yeah.
Uh-huh. Are you aware of anything along those lines in development, or anything at all being developed for constipation?
No, I don't know. I don't think so. I didn't heard anything in the pipeline.
Mm-hmm. about in terms of dosing regimen or route of administration or tolerability? Is there any room for improvement on the drugs that you already have?
I think as far as the like the like the mode of administration, I think we have the PO modes. That's the thing. I think that's where we are, and I think I'm okay with that. Yeah.
How do you think a Parkinson's patient would react to a new drug? I mean, let's say I could give you this combined mechanism of action, but it was available as a subcutaneous injection. Is that a non-starter, or is there an opportunity within the Parkinson's population?
I don't think that the patient will be excited about the injection form, because I have in my clinical practice for last 15 to 18 years, patient usually a little bit reluctant, even the younger patient reluctant to younger to middle-aged patient reluctant to use the injection therapy. Yeah.
Okay. Even if you could tell them, boy, this is going to relieve your constipation
yeah,
markedly?
Yeah, they means if they have not much choice, then they will agree to take it. But initially, it will be a little bit harder as compared to the medication they take by mouth, which is like they don't question about the medication by mouth. But when the question of the injection comes, usually they kind of stop and think.
But the older patients, they are more receptive to subcutaneous, or what's the dynamic there?
Older people, they like as far as the injection concerns, I think the older and the middle age, I think is the same kind of like the resistant we see. And beside that resistant, also the older people have little bit more problem self-administrating the injections and everything. Yeah.
Okay, so it sounds like it's kind of across the board, this resistance, if you will.
Exactly. Yeah. Definitely.
Okay.
Yeah.
Okay. All righty. You know, I heard you mention a little earlier on patients with spinal cord injury, and I'm curious, within that population that you see, how common is constipation?
Yeah, it's a very, very common. Yeah. Yeah, very common. I think the most of spinal cord injury patients have the constipations. Yeah.
What percentage would you guess in your population?
Yeah, I think about about 95 to 98%.
Wow. Okay. Yep. Pretty big number. All right. Where does it fit in terms of all of the things these patients are having to cope with? How big a deal is constipation for a spinal cord injury person?
Yeah, it's a significant in the lifestyle, because many times they are having the weakness in their extremities, and already they have the limited mobility, and on top of that they be having this constipation many times, which is most of the time it is a significant. So definitely is a very, very important things which affect them.
Do they bring it up, or is this something that you ask about?
No,
maybe you don't have to.
Yeah, it's already, because we always ask them, because we know that this is the main important thing. So, and they also like the bring with us. Yeah.
Okay. Okay. Now, have they spoken about this with another physician, or again, is the primary care doctor like yourself sort of front line?
Usually, they already spoken to the other physicians also. They already talked to us. So it's kind of whoever they seeing the most, they usually discuss with them. Yeah.
Oh, okay. And who would that be typically? Who are they seeing the most?
Yeah, typically is primary care physicians. Yeah.
Okay. All right. So not really different from the Parkinson's.
Yeah. No. Yeah. Because Parkinson, many times they are seeing the neurologist frequently, but the spinal cord injury, they may be seeing neurologists, but not that much as compared to the PCP.
Okay. All righty. What's different for these patients in their experience of constipation? What's different in how they talk about it, how they experience it, their concerns, the impact on their life?
They usually like the discuss like the more as compared to the patient with the Parkinson, because this is the spinal cord injury patient have the significant like the severe constipations, and they usually require help. They usually want a physician to help, so they always bring to the physicians to find out what the best they can do.
Okay. Are you telling me they're more motivated in a sense than the
More.
patients?
They are the more motivated. They are more proactive about the getting help.
Okay. Okay. Are their complaints any different? I mean, I think you told me before, let me look at my list, abdominal pain, nausea, loss of appetite, can't participate in activities. Is there anything more pronounced, dramatic that a spinal cord injury patient might talk about?
Yeah, more they have the constipation is their main things. That's what kind of they immediately kind of they bring to the attention. They usually, I don't see they wait that much as compared to the patient with the Parkinson's. Yeah.
Is there any different language that you might use to describe constipation in these patients? I mean, before you were telling me about the phrase you used was a significant lifestyle impact and secondary constipation. Does the vocabulary change when we're talking about spinal cord injury patients?
I don't think so. It's more or less stay same. Yeah.
Are there, I know there's a wide range of spinal cord injuries. I mean, I've heard neurologists have told me it could be anything from disc compression to, a traumatic injury that's resulting in paraplegia, for example. Do you find that there are different types of patients who experience constipation differently within that broader umbrella of spinal cord injury? I mean, are there any subtypes of patients or, patterns in how they experience constipation?
Yeah, I think the patient who have the traumatic spinal cord injury, who having the paraplegia, I think they are the one who suffer the constipation worse as compared to the other patients who having the minor spinal cord injuries, like the secondary to the disc problem or the secondary to the chronic spinal stenosis or something like that, or their treatment for that condition leading the constipation, which is less severe than the people who having the spinal cord injury resulting the paraplegia.
How common within your population is that traumatic patient? I mean, I'm trying to get a sense of, how much they see the primary care doctor versus other physicians, and how commonly this is someone that's showing up at your doorstep.
Yeah, it's not that common as compared to the Parkinson's or some other secondary constipation. And regarding the who is following the patient, most of time primary cares are following after the initial insult, and who take care of the patient. Yeah.
Okay. Just making a note here. So I think you've told me that the traumatic spinal cord injury patient is less common in your practice than Parkinson's, but it also sounds like the spinal cord injury patient has a greater need or a more significant experience of constipation than the Parkinson's patient. Is that
exactly,
true?
Yeah, right.
Yeah?
Yeah, that's right, yeah.
More burdensome in spinal cord, but fewer patients within whom it occurs.
Yeah.
Okay.
Yeah.
How do you approach the management of constipation for a traumatic spinal cord injury patient?
Yeah, I think in the traumatic spinal cord injury, we try to not go in only one direction. We try to involve the multiple treatment plan to help the patient best, because these are the patients who have the severe or significant constipation. Yeah.
So tell me what multiple treatments would look like. What does that mean in this case?
Yeah, the multiple treatment as lifestyle changes, make sure they drink plenty of fruits, fiber supplement. Then we use the osmotic laxatives. Then the newer agent, like we already mentioned, the Linzess, all the locally acting, and sometimes in the worst case scenario, they manually evacuate like every 2-3 days or something like that. So depending upon how bad is the individual patient. Yeah.
Well, to be honest with you, and forgive me if I'm really missed something here, that doesn't sound all that different from what you outlined for Parkinson's. What's different with the traumatic spinal cord injury patient?
Yeah, in Parkinson, I may start with just only them telling to use only one medications, but here I may start with a couple of medications from the start on to go that kind of the little bit more aggressive. Yeah.
Okay, so with the Parkinson's, it might be more of a sequential kind of thing.
Exactly. Yeah.
You're going to throw everything at them with the spinal cord.
Exactly. Yeah.
Okay. What percentage of the traumatic spinal cord injury patients will end up on a prescription Linzess, Amitiza, what have you?
Yeah, I think the most of patients will end up on the prescription prescription for the treatment of their constipation.
What is the number for most? Sorry to pin you down. I apologize.
No, that's okay. Yeah, so about around 95 to 98%.
Okay, and I think that's the same number you gave me for Parkinson's, pretty much. I know I wrote that. I know I wrote those numbers down somewhere. No, I'm sorry. That was the incidence of constipation. What percentage of your Parkinson's folks are going to end up on a lactulose or a Linzess or something?
Yeah, about in that case, about 60 to 65%. Yeah.
So it's a lower percentage with Parkinson's.
Yeah, exactly. Yeah.
Okay, 60 to 65% on a prescription. Okay. So now, what percentage of your traumatic spinal cord injury patients are also taking an opioid?
Yeah, it's about I can say maybe about 20 to 25%.
Okay. Would you contemplate treatment of what you might recognize as opioid-induced constipation any differently from just a constipation that's associated with their injury?
I think the treatment for both will be the more or less same. Yeah.
Same treatment.
Yeah.
Okay. Now, I understand, and correct me if I'm wrong, I think Movantik has an indication that's specific to opioid-induced constipation. Does that matter to you? Does that make a difference in your, perhaps reaching for that product before you would prescribe Linzess, for example?
Yeah, I know the Movantik is specifically for the opioid-induced constipation, but we try like the Linzess or the Amitiza or like that kind of thing, and if they doesn't work, then we try the Movantik also.
Why would you not go for Movantik first if it has the indication? Just curious.
Yeah, The moment, yeah, if it is a opioid-induced constipation, then I can go with the Moventic. There's no problem. But if it is a patient only has a spinal cord injury-induced constipation, then I may try the other medication before I go for the Moventic.
So if you know that they're taking opioids and you suspect that this is opioid-induced constipation, what would
Then
be
I
your
will.
first-line choice?
Then the first line choice, if we are in the fantasy world, then I will try the Moventic first, yeah.
So we're back to the access issue, the insurance issue?
Yeah, because because
Okay.
I have the experience because if I have some special like the military insurance, they usually cover any medication, but if there are some other insurance, they usually have the limited formulary.
I see. Okay.
Yeah.
Okay. Thank you for that. So again, if we're thinking about medication options specifically for the traumatic spinal cord injury patient, where is there room to improve? Is anything different that you might be looking for in new options when it comes to this population?
I think in that case, if some prokinetic agent will be the great help for the patient who have the spinal cord injuries.
Why is that? Why that mechanism in particular?
Because of they have because of spinal cord injury, they don't have that well functioning the peristalsis and everything. So that's where the prokinetic agent come in the picture.
Mm-hmm. Okay. So that would be sort of your favored mechanism of action.
Exactly, yeah.
Mm-hmm.
Because that's where the
Mm-hmm.
problem is there. So you try to fix the problem, yeah.
Mm-hmm. Mm-hmm. I do want to spend some time looking at two slides on the screen, but let me ask you very quickly how often you see constipation in patients with multiple sclerosis.
Usually we have seen, but not that much. And usually the multiple sclerosis patients, constipations, usually most of time is managed by the neurologist as compared to the primary care. Yeah.
Why? Oh, that's interesting.
Because what happened, the patient who have the multiple sclerosis, they see the neurologist quite frequently, and usually the neurologists are actively involved in their care as compared to their passive roles in the other like the patients like the spinal cord injury or Parkinson, because the multiple sclerosis can often have the waxing and waning things, so they usually have the remissions and the relapse and all that kind of stuff. So they have to be tuned with the neurologist on the continuous basis. So they many times the PCP in that case go in the back seat and let the neurologist take the front seat. Yeah.
Okay. Okay. Yeah. So it's more dynamic, I guess.
Yeah.
Uh-huh. Okay. All right. I'm going to bring up two slides for you to look at, as I said. Just let me know when you're ready for me to advance from the first one to the second. And then after you've read the second one, we'll have a chat.
Mm-hmm. We can move to the next one.
All righty.
Yeah, I think so. We can move.
Okay, that's it, just those two.
Uh-huh.
Tell me about your initial reaction to what you read here.
Yeah, I think it's good options to the what treatment option available to us. The way it's like the overall significant improvement in the quality of life and uh, not that many interactions and all that kind of thing. So I think it's a good option. Yeah.
Okay. How does it seem to compare with some of the options you're using today? Is there anything that makes it stand out from the current armamentarium?
Yeah, I think the way they describe this product X, uh, they mentions kind of the like the focus more like the showing the end result, like the significant improvement on quality of the life. I think that's a good standout point, yeah, as compared to what other options we have.
Okay.
And with the no drug interactions and the local acting, so I think that's good options, yeah.
Okay. What might be some other endpoints or specific endpoints you'd want to see data on? You know, when the clinical trials are published, what would you want to see in the literature to really have a good handle on the efficacy, on the quality of life improvements? How can we put a finer point on what you see here?
Yeah, I think the one thing, the mode of the action, second, number of bowel movements, and also about the complications or the side effect of medications. I think these are the three important issues should be stand out, yeah.
Are there any particular side effects with the current drugs that you wish a new option might perhaps eliminate?
I don't, I don't think I don't think anything specifically coming to my mind at this moment. No.
Okay. Let me throw one out there and see if it's of interest to you. What if they could demonstrate that there was absolutely no impact on electrolyte levels? Is that important in this patient population, or maybe not?
I don't think so, because I didn't see that kind of the major issue with the electrolyte imbalance with the current treatment affecting. Yeah.
Okay. Nothing that you're experiencing today has to grapple with.
Because I didn't see the significant number of patients having the significant diarrhea from the taking the medication for constipation, which causing the electrolyte balance. No, I didn't see that much. Yeah.
So the fact that this was specifically studied, or they're suggesting it would be studied in patients with Parkinson's, what if it didn't have that? Would that change its appeal in this population? How important is it to know that it was studied in that particular neurological condition?
I think probably this product X may have the specific kind of the mechanism which will be the main defect in the patient with the Parkinson's, like some neurological issue, and which maybe the product X may working through that neurological pathway, which kind of the overcoming that blockage or obstruction.
Okay, so it's useful, it sounds like.
Yeah.
Okay. So how do you think you would use a product like this, assuming it's studied as shown, the results are as shown, FDA approved? What's the opportunity in your practice?
Yeah, I think there is a definite opportunity there in our practice, and we will definitely use depending upon the product availability, formulary with the insurance plan that what see the patient most, yeah.
Mm-hmm.
Because we practice in the Florida and where the lots of 65 and plus, they have the Medicare replacement plans, yeah.
Okay. Yeah, so that's a real consideration.
Yeah.
If that were not, again, I'm going to ask you to live in fantasy world where, you know, the reimbursement and the out-of-pocket cost are not factors. What are the patients that immediately come to mind? I mean, can you think of a Parkinson's patient with constipation for whom this, you know, is just jumping right out at you as an appropriate option?
Yeah, then we will definitely use the product if we live in the fantasy world. Why don't use the best one you have available? Yeah.
Okay.
Yeah.
Okay. Let me just take you back and have you look these slides over again. But this time I want you to imagine that it reads, for patients with spinal cord injury suffering from constipation. And just give it a quick read and I'll ask you those questions again.
We can move the next one.
So the indication would read treatment of constipation in spinal cord injury patients.
Injuries, yeah.
Mm-hmm.
Yeah, we can move, yeah.
So I'm curious how your reaction might be different if we were talking about this other population of patients. Do you still see the same potential, or is there perhaps a different opportunity?
I see the more potential in the patient with the spinal cord injuries, yeah.
Because why?
Because it's says that it has a superiority over the other treatment, rapid onset of the action, predictable stool movement, bowel movement. Yeah, so all these kind of the features, yeah.
And I know you.
Significant improvement in the quality of the life. So I think that's what the patient with the spinal cord injury may have the issues, yeah.
Okay. Okay. I mean, because the things you highlighted for me weren't really all that different as I'm recalling our conversation about Parkinson's, but the quality of life is just so important in spinal cord injury patients. Don't let me misstate here or put words in your mouth.
No, for the spinal cord injury patient where the constipation, because they may not have that many symptoms, and they may have very few symptoms, and one of them symptom will be the constipation. So it will be their main issue, while the patient with the Parkinson, they may have the multiple other symptoms going on. So the constipation maybe is not in their top list of the symptoms as compared to patient with a spinal cord injury. So, and they usually have the significant constipation. So you want to go with the best treatment available. Yeah.
Okay. Okay.
Yeah.
Very good. Thank you for that. Before I let you go, I think we've got half a minute left. I'm curious if there's anything I haven't asked you that you think would be helpful for my client to understand about constipation in these patients with neurodegenerative diseases. Anything we haven't covered that you'd like to add? You get the last word.
I think patient with the neurogenic disorder, the more education of the patients kind of help them more, because I have seen many times the patient thinks the constipation is a part of the process, part of the aging thing. So many times they don't bring that to the patient. So if the patient kind of be more aware that this is also one of the symptoms, there are the treatment options available, then they will be the more open to discuss with the physician.
Uh-huh. Uh-huh. Okay. Terrific. Thank you for that. Anything else?
I don't think so, yeah.
All right. Dr. R., thank you so much for your time this evening. This was an illuminating conversation. I appreciate it.
No problem. Thanks. Thanks for opportunity to discuss with you. Yeah.
Thank you. Bye-bye now.
Bye. Good.